I will just going to talk about the different types of X-rays, how it is important in Viva, and how the questions are being asked in exam. That is going to be our discussion today. So hope you are able to see the page, right? Okay. So now we are going to see how X-rays are being asked in our Viva examination. Okay. So now, whenever you take any X-ray, you have to start with what type of view it is, about the exposure and penetration, whether it is an inspirated film or expirated film, the rotation is present or not, angulation, soft tissues and bony structures should be commented, trachea position to be mentioned, hilum and mediastinal level has to be mentioned, the diaphragm, lung fields, and the heart should be explained whenever you're going to present any X-ray in your Viva. Okay, so what are the types of view you're going to have? Okay, the first one is whenever you're going to present the X-ray, you're going to say the X-ray is going to be uh, of a person who is going to have a kind of X-ray, so should be explained. For that reason, you're going to tell so and so a patient, 45 years old male, X-ray, PA view or AP view, okay, with the film marked at right side as R, and you have to tell about the further descriptions. Okay, so PA view, AP view, and lateral view are available. Okay, PA view. PA view is when the ray of beam is from posterior anterior with the film in front of the patient. Okay, so what happens here is the film is in front of the patient, and the patient is going to stand like this, and the film is going to be in front of the patient. Okay, and the beam is going to form from posterior, and it is going to move anteriorly. Whereas we have AP view where the film is going to be placed over the back of the patient, and the ray is going to come anterior to posterior. So based on the movement of the rays, you're going to have a AP view or a PA view. Okay. So this is how they take the X-rays. Okay. And lateral view is going to be again, patient film is going to be placed laterally. Now, whenever you have a patient, okay, so coming to you with the X-ray being taken, okay, in those patients, what you're going to see is you're going to see the clavicles, okay. So when the clavicles is seen over the lung fields and more horizontal, then it is going to be more of a PA view, okay. Whereas so here, clavicles are seen over the lung fields and more horizontal, whereas here the clavicles are seen over the apex of the lung field, and it is going to be more oblique. Okay, scapula. Scapula, if you see, the inner borders of the scapula are away from the lung fields. Okay, inner border of the scapula is away from the lung fields, whereas in AP view, the inner border of the scapula is going to be more into the lung field. Okay, more into the lung field. That is one important difference. Then ribs. Ribs are posterior ribs are better seen in PA view, okay, and it is going to be more oblique, okay, whereas here the anterior ribs are more commonly seen, and it is more bend and horizontal, okay, more bent and horizontal. Apparently cardiomegaly is not seen here. Whenever you take AP view, there will be a apparent cardiomegaly. Okay, that is one thing. Okay, so you cannot comment about cardiomegaly whenever you are going to take a AP view. Okay, and spine is better seen in PA view, and it is not seen in AP view. Okay, the these are the important differences which you have to note in these patients with note in patients with PA view and AP view. Okay, next is exposure and penetration. Okay, whenever an X-ray is having black in color, okay, whenever the X-ray is black in color, it is mean it is overexposed. Whenever it is light in color, it indicates that it is underexposed. Okay, overexposed, underexposed. So this is the X-ray, which is going to be an overexposed X-ray. Okay, and this X-ray, you can see that is white thing. This is an underexposed X-ray. So that is very important thing to note here. Okay, then next is inspirator film and expirator film. How you are going to differentiate? Okay, if you take an inspirator film, the inspirator film, you can see the ribs, okay, and you can count up to 10 ribs, okay, 10 ribs. And if you take a AP expirator film, you can see what to say, the crowded ribs can be seen in AP view. Okay, the crowded ribs can be seen in the AP view. That is very important. Okay, whenever you are whenever you are going to see an PA view and inspirated film, you're going to count the number of rips. Okay, whenever you count, you can get minimum 8 rips to 10 rips will be seen. Okay, whereas in the expirated film, you can see the crowded rips. Okay, crowded rips, that is very important thing. Okay, and expirated film is usually not done in all conditions except for pneumothorax. Okay, so we usually tend to do expirated film in pneumothorax. Okay, then this is very important. Then how you're going to see the rotated film? Okay, so if you take this X-ray, you can see the X-ray showing this X-ray. If you take, you can see the middle part, midline. Okay, and if you see the head of the clavicle, it is equidistant from equidistant from both the sides. Okay, whereas if you take a rotated film, you can see the unequal distance. Okay, whenever this distance decreases, okay, this distance increases, then it is rotated towards the increased distance sides. Okay, if you take here, there is going to be increased distance. Whenever there is an increased distance, it means that the film is rotated towards the side which has an increased distance. Okay, increased distance. That is very important. Very important. Then you have to comment about the brush shadows. Okay, you can see the brush shadows here. Okay, and you have to tell about the supraclavicular volume. Okay, and tell about any axillary mass is there or any axillary area gas is there. Okay, for example, subcutaneous emphysema. Okay, these things to be mentioned, and you have to tell about the bony structures. You have to tell about the sternum. You have to tell about the ribs. Okay, you have to comment about the spine, and even shoulder girdle and clavicle should be commented in the bony structures. Okay, so these are the few things which you are going to consider whenever you are going to tell about any X-ray, and this is very important for you people. Okay, apart from this, they can also ask about the diaphragm. Okay, diaphragm. So if you see here, if you see here, so if you see here, if you draw a line from here, okay, so if you draw a line from here, okay, if you draw a line from here, you can see the right diaphragm is elevated, okay, whereas the left diaphragm is decreased. Okay, decreased. So whenever the right diaphragm is elevated, this is a normal one. Okay, normal one. And after that diaphragm, you have to tell about this one, which is called as cardiophrenic angle, and you will also should comment about this part, which is going to be costophrenic angle. This costophrenic angle is usually obliterated in patients with pleural effusion. Okay, pleural effusion. So if you take any pleural effusion patient, if this is the lung of the patient, this is called obliteration. Okay, the space. Now, if you see the space is obliterated. Okay, so this obliteration you can see here. This obliteration you can see here. It should be like this. Okay, rather now it has become obliterated. Okay, so this obliteration is very important thing which you see in pleural effusions. Okay, pleural effusions. Then next is sometimes there can be flattening of the diaphragm. Okay, flattening of the diaphragm means the diaphragm, both the diaphragms will be at the same level. Okay, when both the diaphragms can be at the same level. When both the diaphragms are at the same level, it means that it is going to be seen in conditions like emphysema. emphysema. Okay, in emphysema, you can see the flattening of the diaphragm. Okay, that is very, very important. Okay, these are a few things you have to consider. Okay, few things you have to consider. Next is this is very, very important. Then next is so this is what I was telling, flattening of diaphragm. Okay, flattening of diaphragm. Sometimes you can get straight line. The diaphragm is straight. Okay, both the diaphragm at the same level in emphysema. Then next is sill-out sign. Okay, sill-out sign. What is sill-out sign? Okay, and cardiomegaly. I will explain cardiomegaly. If you take this as an X-ray, okay, so what you're going to do is you're going to draw a line at the center. Okay, line at the center, and you're going to calculate this distance and this distance. A plus B, okay, when compared to C is more than 50%, okay, then it is going to be indicating that there is cardiomegaly. Okay, so plus A plus B, okay, when compared to C by 50%, then it is going to be called as cardiomegaly. Okay, cardiomegaly. Okay, A plus B compared to C is more than 50%, then it is going to be called as cardiomegaly. That is very, very important thing to note here. Okay. So these are few things which I felt very, very important to discuss here. So now I will show you few X-rays and we will discuss these X-rays, how these X-rays are going to make a diagnosis. Okay. So now you're going to tell in the comment section whenever you see this X-ray, what is the findings you get to see. Okay. So now if you take this X-ray, okay, so this is the normal position of the diaphragm, okay? And if you see here, there is a thing like this, okay? So here, if you see here, this area, the whole area is, it is it is white in color, okay? White in color, radio opaque. Whenever the whole thing is radio opaque and you get a crescent like margin here, okay, present like margin here, which is called as a S sign, you can label this as pleural effusion. Okay, this is a case of pleural effusion. Okay, pleural effusion. So this is a case of a pleural effusion over the right side. Okay, right side. So it's a homogeneous opacity in the right hemithorax, obliterating the costiophrenic angle. So it is going to be a case of pleural effusion. Okay, pleural effusion. Hope this is clear. Okay, next is you can see here this picture. In this picture, you can see an X-ray where you can see a space like this. Okay, and this space usually is going to be cavity, and more than this picture, usually the cavity will have a air fluid level. Okay, air fluid level. So here there will be fluid, which is radio opaque, and here you're going to get air which is going to be hyperlucent. Okay, hyperlucent. So this kind of picture with the surrounding rim of cavity, uh, rim like this. Okay, and this is going to be called as a lung abscess. Okay, lung abscess. So this is also again very, very important. You can see in your day-to-day practice. This is a case of lung abscess. Okay, then next X-ray. Okay, here, if you see here, this appearance where you get a apparent cardiomegaly like structure, and this cardiomegaly structures looks like a money bag or a leather bag or a water bottle appearance. Okay, and this indicates that the patient is having pericardial effusion. Okay, so this is going to be indicating that patient is having pericardial effusion. So this indicates pericardial effusion. Okay, so this is going to be a money bag or water bag appearance. Okay, water bag appearance. Okay, water bag appearance. Okay, water bag appearance. Okay, so this is again you can get to see in our day-to-day practice patient having pericardial effusion coming to you with a water bag or a money bag appearance. Okay, that is again common thing. அடுத்த விஷயம் என்னன்னா you can see here this is an x-ray. Okay, this x-ray you can see an hyper uh, exposed or overexposed x-ray where bilateral you get lot of cotton wool like spots. Okay, cotton wool like spots, these are called as cannonball metastasis, usually seen in patients with tumor. Okay, secondaries you can get. Okay, so secondaries in lung you can get cannonball metastasis, which looks like cotton balls placed over the lung. Okay, placed over the lung. And what is this one? This is an X-ray where you see lot of minute dot things. Okay, so these lesions are going to be 2 to 3 millimeter in size. 2 to 3 millimeter in size. When these lesions are 2 to 3 millimeter in size and dispersed in all zones of the lung, and this is going to be called as miliary mottling. Okay, miliary mottling. Usually, miliary mottling is seen in patients with the miliary tuberculosis. Okay, miliary tuberculosis, but it also can be seen in cases of silicosis, etc. Okay, so this is miliary mottling. Okay, miliary mottling. Okay, so this is very, very important X-ray which you get to see in your Viva table. Okay, and next X-ray. Okay, next X-ray. If you see this X-ray, you can see one important finding where this is an X-ray. This is the lung. Okay, and you get a horizontal line. Whenever you get a horizontal line where here there is air, okay, and here there is going to be fluid, okay, and you can also get one margin like this. Okay, margin mostly like this. Okay, so this is called hydropneumothorax. Okay, hydropneumothorax, and this you can see here. This is going to be in air here, and this is going to be water here. Okay, and this is going to be called as hydropneumothorax X-ray. Okay, hydropneumothorax X-ray. Okay, you can easily identify this hydropneumothorax. Okay, hydropneumothorax. This is very, very important thing. Okay, again this X-ray will be kept in your exam. Okay, and next is again this is going to be pleural effusion. You can see the obliterated costophrenic angle. Okay, costophrenic angle, and this is called as L-shaped Ellis curve or golden S sign. Okay, golden S sign. Then next X-ray is going to be this one. Okay, so whenever you get an X-ray like this, where you get and wherever you get a haziness like this, okay, haziness like this, where you get lot of dilated areas here, and these dilated areas indicate that this is a case of bronchiectasis. Okay, bronchiectasis, but you have to confirm with HRCT only. But your chest X-ray will give a clue about the diagnosis. So a clue about the diagnosis. Then next is you see this X-ray. This is again an overexposed X-ray. Okay, it is going to be a PA view. You can see the clavicle is equidistant on either side. Okay, on either side. But you see here, there is one radio opaque region. Okay, this radio opaque region indicates that this is a case of consolidation. Okay, consolidation involving the left upper zone of the lung. Okay, left upper zone of the lung, and this is going to be a consolidation. Okay, it is going to be mostly a lobar pneumonia. Okay, lobar pneumonia. Then next is this one. Okay, so what is this one? What is your diagnosis based on this X-ray? And you see this X-ray, what is the diagnosis you're going to make here? Emphysema, very good. So if you see here, that is going to be flattening of the diaphragm. Okay, and you get a tubular heart. Okay, and you can see the hyperlucent lung fields. Okay, hyperlucent lung. Last week also we discussed, right? So you can see the hyperlucent lung fields. Okay, you can see the increased space between the ribs. Okay, all these indicates that this is a case of a emphysema, and it is easy to identify. These are the points you're going to tell you in an exam also with regard to emphysema. Okay, with regard to emphysema. Next is, what is this X-ray? You can see here in this X-ray, you can see the straightening of the left heart border. Okay. The straightening of the left heart border is usually seen in mitral stenosis. Okay, mitral stenosis. So in mitral stenosis, you get to see this picture. Okay, and in mitral stenosis, what is going to happen is that is going to be this is the heart of the patient. This is the heart of the patient. So in the heart of the patient, what is going to happen here is this because of the stenosis here, this part enlarges. This part enlarges. When this part enlarges, okay, enlarges, what is going to happen is this space increases. Space increases. Okay, when this space increases, what is going to happen? There is going to be left atrial enlargement. Okay, and this is going to be seen as the straightening of the left heart border, and this is going to be seen in patients with mitral stenosis. Mitral stenosis. Okay, mitral stenosis. This is very important thing. Okay, very important thing. Okay. Then this X-ray is going to be again telling that there is a pneumonia patch here, okay? Pneumonia patch here or consolidation patch here. Okay. Then next is this one. Okay. So you can see here, this is a case where you see lot of enlargements in the hilar area bilaterally. Okay. This bilateral hilar enlargement indicates that it is hilar lymphadenopathy, and it is usually associated with the cases of usually cases of sarcoidosis, okay, sarcoidosis, or even in tuberculosis, you get TB, in lymphomas, okay, all these conditions you get bilaterally hilar lymphadenopathy. Then what is this one? This is going to be, you can see the trachea is shifted to same side, okay. When trachea is shifted to same side and you get a radio opaque lesion like this, okay, radio opaque lesion like this, and the trachea is shifted towards the same side, then it is going to be collapse of the heart, or it can be pneumectomy. Okay. Whereas if the same patient, if your trachea is shifted to opposite side, okay, then it is going to be pleural effusion. Okay, pleural effusion. That is very important. Okay, very important. You can see here. So here the trachea, it's the same picture you're getting here. Okay, but what happened to the trachea? Trachea is shifted to the opposite side. When trachea is shifted to opposite side, it is pleural effusion. When trachea is shifted to same side, it is going to be collapse. Okay, collapse. Very important point you have to note here. Okay, very important point to note here. This is very important. They can ask you in either Viva also. Okay, Viva also. Then next is this is going to be again pneumonia. You can see the right upper lobe pneumonia. Here you can see the lower lobe pneumonia, okay, or middle lobe pneumonia, more of middle lobe. Lower lobe means you have to go for more posterior, okay, posterior only you can see. This is going to be more of a middle lobe pneumonia, because if you see here, this is going to be the marking, which is going to be, this is going to be the upper lobe. One second. Okay. So this is going to be the like this. So this is going to be the upper lobe. This is going to be the middle lobe. Okay, and this is going to be the lower lobe. Okay, that is very important surface marking you have to know here. Okay, so again, that is going to be again a complex, I mean, explanation is needed for how to see for the surface marking and all. But again, beyond the scope of today's discussion, we'll discuss in some other time about how to delineate the upper lobe, middle lobe, and lower lobe. Okay, then next is okay, and this one. This is again pneumonia. Okay. Then what is this one? What is this X-ray? You can see the air fluid level. Okay, air and fluid. This is lung abscess. Okay, lung abscess. And you can see here, this is actually a cavity. Okay, there is a cavity here. And in this cavity, you can see there is lot of air here. Okay, and this is indicating crescent sign in or monod sign in aspergilloma. Okay, aspergilloma. Okay, that is again important thing. Okay, so this will not be kept for you, but this will be kept for you. Lung abscess will be kept for you in exam. Okay, then next is this one. Okay, what do you get to see here? What do you get to see here? You see here lung, which has bronchovesicular markings, but here it is going to be having only air. And this is going to be a case of pneumothorax. Okay, this is going to be a case of pneumothorax. Whereas this one, you see the uh, hyperlucent picture all over the lung. Okay, all over the lung. And this is going to be your emphysema. Okay, emphysema, where emphysema, you are going to have a hyperlucent picture like this on either side, and you are going to hit a tubular heart. Okay, tubular heart. So this is again very, very important, very, very important. Okay, so this is very important thing. Okay, next is next. This one, this one again, you can see the paratracheal lymph nodes, pretracheal lymph nodes getting enlarged. Usually it can be sarcoidosis or tuberculosis or lymphoma. And what you get to see here, again, it is going to be pleural effusion, which is seen over the one side of the lung, okay, one side of the lung. Then next is, you can see here, soft tissue. What do you see in the soft tissue here? What do you see in the soft tissue here? You see the same air here of different echo density or different density. You can see the air here, you can see the air here, you can see the air here. Okay. And these things indicate that this is going to be a subcutaneous emphysema. Subcutaneous emphysema, very, very important thing you have to know. Okay. Subcutaneous emphysema. Then miliary mottling. Miliary mottling. You can see here miliary mottling. Then this is again metastasis. Metastasis. This is again uh, leather bottle or water bottle appearance. This is going to be your case of pericardial effusion. Pericardial effusion. Okay. So these are few X-rays which I want you people to know. Okay. Few things. What does this one indicates? This is a metallic valve. Okay, metallic valve. So this is a mitral valve replacement surgery being done in this patient, and this is a metallic valve. Okay, metallic valve. That is very, very important. Okay, very, very important. And this indicates that patient has undergone a surgery. Epstein's. Okay. So pericardial Epstein's anomaly, you will get a usually in pericardial effusion, you will get sometimes double shadow also. Okay, double shadow also in pericardial effusion. Okay, pericardial effusion. Okay, that is very, very important. Okay, so and again the hard border will be little black in color. Okay, little black in color in pericardial effusion. Okay, pericardial effusion, you are going to get a black border or stenciled border, they call it as. Okay, that you can see. Okay, so that is one thing which can differentiate. So whenever you have a case like this, whenever Epstein's anomaly is there, in Epstein's anomaly, usually you will get a box-shaped heart. Okay, the heart will be little box-shaped. Okay, that is what. But here you can get a stenciled border. Okay, thickened border, black border. Okay, that is going to be seen here in patients with pericardial effusion. Okay, that will differentiate. Okay, so these are few things, X-rays which are important for you to understand. Okay, understand. Mm, okay, so these are few X-rays. Okay, what is this X-rays in telling you? What is this one? This appearance. This indicates this is a case of multiple air fluid level or grape-like appearance. Okay, whenever you get a multiple grape-like appearance, then this is going to be a case of bronchiectasis. Okay, bronchiectasis, you will get lot of grape-like appearance. Okay, grape-like appearance. So these are few things about X-ray which I feel very, very important for you to understand and know. Okay, again, you can anytime come back to me for any doubt about the X-rays. Okay, we will discuss any doubts is there. Okay, so these are few X-rays which are kept in medicine. Okay, pediatrics is different, surgery is different. But here, in medicine, these are the few exercises which will be kept for you for definite. Okay, and we will see how to go about with these things in exam. Okay, so study well. Okay, we will meet again in the next session. Okay, uh, yeah, we'll discuss already. I have discussed respiratory sounds, I think so. I will send you the PDF. Uh, okay, I'll send you the PDF. Okay, definitely video. I will ask them. Okay, I will ask them. Definitely, we will. I will ask them and let you know. And we will discuss next class something like instruments, or we can discuss something like drugs for in the next class. Okay. So study well. All the very best. Thank you.